Good afternoon, everyone. Thank you for attending our Symposium number 9, Prevention of Ventilator-Associated Pneumonia, Ventilator-Associated Events. We have a panel of distinguished speakers to share with us their expertise. I would like to introduce our first speaker, Dr. Sashila Punampalavana. And Dr. Sashila is a consultant infectious disease physician at the University Malaya Medical Center. She is a committee member of the Malaysian National Antimicrobial Resistance Committee and is involved in the development of the national guidelines in infection prevention and antimicrobial stewardship. She was awarded the 2020-2021 Fulbright Scholarship and was attached to Hospital Epidemiology and Infection Control Department at the Johns Hopkins Hospital. Her main interest is in hospital-acquired infection, antimicrobial stewardship, and multi-drug resistant organisms. Please put your hand together to invite Dr. Sashila.
So very good afternoon to everyone, and thank you for the kind introduction. So I'll be talking on the strategies to prevent ventilator-associated pneumonia, and I'll be concentrating more on adults. So these are my disclosure. So as you know, ventilator-associated pneumonia is the commonest hospital-acquired infection among critical care patients, especially in low and middle-income countries, at a rate of about 18 per 1,000 ventilator days. And the rate of multi-drug resistant organisms in this region is also very high. MRSA and carbapenem-resistant Acinetobacter can be up to more than 60%. The IDSA and SHIA came up with the strategies to prevent ventilator-associated pneumonia a few months ago, and it's a very comprehensive guideline. However, just to bring to your attention, due to the limitation of the traditional definitions of ventilator-associated pneumonia, as Dr. Habad will be letting you know later in his talk, and also the paucity of ventilator-associated pneumonia and VAE literature, this guideline prioritized strategies with improvement in objective outcomes such as duration of mechanical ventilation, length of ICU stay, as well as mortality rather than outcome of ventilator-associated pneumonia themselves. The guideline is divided into 3 parts. One is essential practices, the other one is additional approach and generally not recommended. So under essential practices, the rationale is these interventions have good evidence that the intervention decreases the average duration of mechanical ventilation, the length of stay, mortality, and/or cost, and has its benefits likely outweigh risk. There are 8 essential practices, and the first one is to avoid intubation and prevent re-intubation. So it recommends to use high-flow nasal oxygen or non-invasive positive pressure ventilation or NIV as appropriate whenever safe and feasible. So as you know, there are different types of NIV in your hospital. It could be face mask, it could be mouthpiece, it could be even a nasal piece, or now helmet, as you can see in the picture on the F. And also on the far left is the high-flow nasal cannula. So these guidelines this recommendation was based on quite a number of meta-analysis of randomized controlled trials that showed high-flow nasal cannula prevented intubation in hypoxic respiratory failure, as well as re-intubation after extubation in critically ill patients and post-operative patients compared to conventional oxygen therapy. Similarly, NIV was associated with lower rates of intubation, re-intubation, ventilator-associated pneumonia, and mortality compared to conventional oxygen therapy in patients who had acute hypercapnic or hypoxic respiratory failure. But what about comparing high-flow nasal oxygen and NIV? Which one did better? Well, it showed that high-flow nasal cannula and NIV were similar in their capacity to prevent re-intubation and post-extubation renal failure and HAP. This was shown in a meta-analysis of 22 studies that was published in 2020, about 4,000 patients, and it showed there was no significant, the NIV did not significantly lower the incidence of re-intubation in patients who were extubated. And there was, however, and it also showed that the high-flow nasal cannula and NIV reduced hospital-acquired pneumonia compared to conventional oxygen therapy. But there was no significant difference in the decrease of HAP or post-extubation acute respiratory failure between both NIV and high-flow nasal cannula. Also, meta-analysis of randomized controlled trials have shown that if you give the patient NIV after early extubation versus standard weaning, it actually reduced mechanical ventilation and HAP. And also, there was a randomized controlled trial that was published in 2019 that showed that combining high-flow nasal cannula with NIV immediately after extubation may further decrease the risk of reintubation in patients with high risk of extubation failure, such as those who are older or had acute respiratory illness, compared to using high-flow nasal oxygen alone. Recently, since COVID came about, many ICUs started using helmet NIV, and actually there was a randomized control trial. There was a meta-analysis of randomized control trial of 21 randomized control trial of about 3,000 patients that showed that helmet NIV may be associated with better outcomes than face mask NIV with regards to re-intubate or needing to be intubated, as well as mortality. However, they did not show any difference in the risk for hospital-acquired pneumonia based on a recent randomized controlled trial that was published in JAMA. However, you should use caution when considering NIV to manage patients with impaired consciousness and other contraindication, or when continuing NIV in patients who are already dyspneic and gas exchange fail to rapidly get better with NIV. So the next guideline was, the next recommendation was to minimize sedation. So it's important that we minimize sedation in ventilator patients whenever possible, because there was this longitudinal prospective study of 42 ICUs that showed that sedation intensity independently predicted increased risk of death, delirium, as well as reduced chance of early extubation. It also showed that agitation level independently predicted subsequent delirium. So the guideline says avoid benzodiazepines in favor of other agents to manage agitation. As you know, most of our critically ill patients have got renal and liver dysfunction, and therefore they have trouble clearing benzodiazepines, and this may cause them to be over-sedated, longer ventilation, and therefore leading to ventilator-associated pneumonia. The other alternative agents that may be used are analgesics for pain, reassurance, and antipsychotics for anxiety, and dexmedetomidine or propofol for agitation. So there have been studies that shows, sorry about this, it's going really fast. There's been studies that have shown actually meta-analysis of randomized controlled trials that have shown that in patients who are mechanically ventilated, dexmedetomidine and propofol had shorter duration of mechanical ventilation and ICU length of stay. Similarly, in NIV patients in ICU, meta-analysis about 12 randomized studies showed dexmedetomidine decreased the need for intubation, lowered delirium, and shortened length of ICU stay. There was a retrospective single-center study in Boston of about 9,000 patients that showed that dexmedetomidine was associated with lesser ventilator-associated events, about 12% compared to benzodiazepine and propofol, which was 66%. The other recommendation is to use a protocol to minimize sedation. This includes nurse-driven protocols for targeted light sedation or daily sedation interruption for patients who are especially ventilated for more than 24 hours and did not have any contraindication. Based on a meta-analysis of 6 randomized trials, it showed that protocols minimize significant sedation, significantly shortened ICU length of stay compared to no protocol. However, there was no sufficient evidence to recommend one protocol over the other. A very recent meta-analysis was published in 2022, and this included 45 randomized controlled trials, mainly from China, but there were also from US and Australia and Europe, which showed that daily sedation interruption significantly reduced ventilator-associated pneumonia by about 50%. And it also significantly reduced ventilator mechanical ventilation duration, ICU length of stay, as well as the need for tracheostomy. The guideline also recommends implementation of a ventilator liberation protocol. It has been shown that initiating these protocols were associated with extubation of patients on an average 1 day earlier. So therefore, they recommend assessing readiness to extubate daily, and also to keep in mind that protocols to minimize sedation, mobilize patient, and liberate them from mechanical ventilation may work synergistically. So the next recommendation is to maintain and improve physical conditioning. So based on, again, 2 meta-analyses and of quite large randomized controlled trials, early exercise and mobilization programs actually decreased the incidence of ICU-acquired weakness, shortened duration of mechanical ventilation, reduced ICU length of stay, as well as reduced ventilation-associated pneumonia, and it also showed to be cost-saving. The next guideline is, I'm sorry, I'm going quite fast, 20 minutes to cover everything. The other recommendation is to elevate the head of the bed to 30 degrees to 45 degrees. So this was based on a Cochrane review that was published in 2016 that showed that elevating the head of the bed to more than to 30 to 60 degrees significantly reduced ventilator-associated pneumonia with a risk ratio of 0.36 compared to being supine at 0 to 10 degrees. There was no difference in mortality, duration of mechanical ventilation, mortality, or length of stay. So the next guideline, I think this is something interesting, is to provide oral care with toothbrushing but without chlorhexidine. So, regular oral care with chlorhexidine has become a standard of practice in our region. I'm not sure about your ICUs, but in my ICU, they definitely use it in my country. But surveys had also showed that 60 to 70% of ICUs in Europe and North America provide oral care with chlorhexidine on mechanically ventilated patients daily. However, there were limitations to the studies that actually recommended this previously. So based on a meta-analysis of 16 randomized controlled trials that between comparing chlorhexidine versus control in about 3,500 patients, it showed that fewer VAPs were actually seen in cardiac surgery patients who were using chlorhexidine, but there was no significant difference in non-cardiac surgery patients, especially those who were in non-randomized controlled trials. There was also a trend towards increased mortality among patients receiving chlorhexidine oral care. And because of that, the SHIA guideline says provide oral care with toothbrushing but without chlorhexidine. But there was also a recent Cochrane review that showed that toothbrushing versus no toothbrushing and daily toothbrushing was associated with significantly lower VAP, shorter duration of mechanical ventilation, and shorter ICU stay. And also it showed a trend towards lesser mortality, but this was not significant. And again, this systematic review by Cochrane also showed that chlorhexidine oral care, though reduces VAP, it was trending towards causing increased mortality. The next recommendation is to provide early enteral versus parenteral nutrition. So as you know, every critically ill patient in ICU for more than 48 hours should be considered at risk for malnutrition. The mechanical nutrition therapy that's possible for these patients are oral nutrition supplements, enteral nutrition, as well as parenteral nutrition. So the ESPEN guideline, which came out in 2019, did very nice meta-analysis of various comparisons. And one of it was to look at early enteral nutrition, which is within 48 hours, versus delayed enteral nutrition. And they found significant reduction of infectious complications in those with early enteral nutrition, as well as shorter ICU and hospital length of stay. They also did. There was also a meta-analysis in the ESPEN guidelines that showed early enteral nutrition versus early enteral nutrition showed reduction in infectious complications compared to early parenteral nutrition. However, they do mention you should withhold enteral nutrition in critically ill patients with uncontrolled shock or upper GI bleed or other complications such as bowel ischemia, bowel obstruction. So you need to actually assess your patients properly before you, decide, even when you use these guidelines. So the next recommendation was to the change of ventilator circuits only if visibly soiled or malfunctioning or per manufacturer's instruction. So, so this guideline, it has shown that changing of ventilator circuit as needed rather than on a fixed schedule had no impact on ventilator-associated pneumonia rates or patient outcomes. So this was based on a meta-analysis of 10 randomized trials, and it showed that circuit change every 7 days versus 2 days, or no circuit change versus changing every 2 to 7 days showed no difference. So therefore, but what it did show was there was a trend to reduce the risk of pneumonia as circuit change intervals were extended. This study also showed there was estimated yearly cost savings with not changing the circuit based on a schedule or fixed schedule. So now I'm going on to the additional approaches. So the additional approaches, basically, the rationale would be good evidence. There's good evidence that the intervention improves outcome in some population, but may confer some risk to others. So one of these interventions that they have recommended is the use of selective oral, or SOD, or selective digestive decontamination, SDD, in countries and ICUs with low prevalence of antibiotic-resistant organisms. So I thought I'll go through two studies, one highlighting a country with high MDRO and another one with low MDRO rates. So this is the first study, which is a meta-analysis of 6 studies from ICUs that have low levels of antibiotic resistance. So these were studies mainly from Netherlands and Germany, and they showed when compared to standard care or placebo, SOD had 16% reduction and SDD 18% reduction in hospital mortality. And SDD was more effective than SOD alone for hospital mortality. And similarly, this finding was found in ICUs. Now, a study was done in a randomized control study was done in 13 European ICUs, which had at least 5% of their BSIs had ESBL Enterobacteriaceae. That means they had quite a high rate of MDRO. And they looked at their baseline rate of certain parameters. So their baseline number of patients were about 2,000. And then they had a post-intervention, they had an intervention period where the patients were divided into 3 groups. They had the chlorhexidine group, about 2,000 patients, the SOD group who got SOD, about 2,000 patients, and SDD, another 2,000 patients. And what they found was the ICU with these high rates of, or moderate to high rates of MDROs, there was no difference in the MDRO BSI rates in the pre-intervention or the post-intervention, and even between the different groups. And also the crude mortality was the same at baseline as well as in the intervention period in the 3 arms. They did not look at ventilator-associated pneumonia or other outcomes, just at crude mortality, and this is what they found. So based on this, the IDSA guideline recommends that consider using SOD or SDD to decrease microbial burden in ICUs with low prevalence of MDRO, which as a surrogate they use less than 5% of ESBL. And it is not recommended in countries with high prevalence of MDRO, which is more than 5% of ESBL, and that would be something in my country and many other countries in our region anyway. They also caution that the ICUs that do implement this strategy should actively monitor the impact on antibiotic utilization, antibiotic resistance, and C. diff. The other additional approach is based on evidence that it may lower VAP rates, but insufficient data to determine the impact on duration of mechanical ventilation, length of stay, or mortality. So the first one is to consider using endotracheal tubes with subglottic secretion drainage ports to minimize pooling of secretion above the endotracheal cuff in patients likely to require more than 48 to 72 hours. So this was a meta-analysis of 20 randomized trials that showed that the use of these endotracheal tubes with subglottic drainage reduced VAP. and the reduction was mainly seen in patients who were expected to, who were intubated for more than 48 to 72 hours. So they strongly recommend that you should not extubation followed by immediate reintubation just to exchange a conventional endotracheal tube for a subglottic secretion drainage endotracheal tube is not recommended. Okay. So the next one is to consider early tracheostomy. So this was based on a meta-analysis of 17 randomized controlled trial that showed early tracheostomy, that is within 7 days, may be associated with a 40% decrease of VAP, less time on mechanical ventilation, and fewer ICU days. But there was no difference in mortality. However, they do mention that decision makers should integrate the potential benefits with each patient's value and preference when determining whether tracheostomy is needed. The next thing is that is quite commonly debated is to consider post-pyloric feeding tube placement in patients with gastric feeding intolerance at high risk of aspiration. So there are many meta-analyses that have been done, and they vary in their outcomes. Whether does it really decrease VAP or ICU length of stay compared to just gastric tube feeding. So a meta-analysis of 11 randomized controls trial kind of shows there was a trend towards less pneumonia in patients who were treated with post-pyloric feeding tube. However, you need to keep in mind that to place a post-pyloric tube, you need special expertise, and it's less physiological than a gastric feeding tube. So the ASPEN guidelines, as well as this guideline, recommends that gastric access should be used as a standard approach to initiate enteral nutrition, but post-pyloric feeding should be reserved for patients with gastric feeding intolerance or risk of aspiration. So the next, I'm not going to go through all of them here, but I just, these are generally the guidelines that are not recommended, basically with the rationale that they are inconsistently associated with low ventilator-associated pneumonia rates and no impact or negative impact on duration of mechanical ventilation, length of stay, and mortality. So that includes oral care with chlorhexidine, which I've already discussed earlier. Use of probiotics is also not recommended at this point. And the other thing, you can go through the list, but I wanted to point out chlorhexidine bathing. So the recommendation for chlorhexidine bathing is not recommended. I just want to highlight that it was based on observational studies that chlorhexidine actually improved ventilator-associated rates, but there was no randomized control trial. So therefore, these experts actually put it under not recommended. However, you have to be aware that chlorhexidine bathing, especially in ICUs, actually improve or reduce other hospital-acquired infections, especially CLEP-Cs and MDRO rates, and that has been shown quite clearly. The other thing is stress ulcer prophylaxis. Stress ulcer prophylaxis definitely reduces upper GI bleed, but the randomized controlled trials and the huge meta-analysis has not showed that it reduces VAP or mortality or reduce intubation days of intubation. Even recently, there's a randomized controlled trial that compared placebo with pantoprazole, and it didn't show it reduced VAP, though it reduced or mortality. The other thing I just want to highlight on is the importance of surveillance. It's very important that every hospital has a surveillance of ventilator-associated pneumonia so that we know the magnitude of ventilator-associated pneumonia and the trends in our hospital, and to guide intervention strategies and monitor the impact of the interventions that we put in. And what should we use? Well, this guideline says use ventilator-associated events. I think Dr. Habat will tell us more about the current definitions. And who should be doing the surveillance? I think we should go towards, instead of working in silo, just the infection control doctor does it, or infection control nurse does it, or the ICU doctor does it. I think now it's more of a multidisciplinary team approach where there's the infection preventionist, the critical care physician, respiratory therapist, and even IT team should be involved in the surveillance. With that, I thank you.
Thank you, Dr. Sashila, for an interesting talk. Our next speaker is Prof. Stephen Habath. His topic is controversies in definition of VAP. Prof. Stefan Haberth earned his 1993 medical degree from the Ludwig Maximilian University in Munich, Germany. He completed his master's degree in epidemiology at the Harvard University in Boston. He is board certified in infectious diseases and was appointed full professor at the University of Geneva in 2018. Dr. Haberth's work has garnered several awards. His group is currently conducting several clinical and epidemiological studies to evaluate key questions related to the control of the acquisition, transmission, and infection by multi-drug resistant microorganisms, and related clinical and health economic burden. He participates in several ongoing large-scale EU-funded studies and coordinated the DRIVE app project to address this public health threat. Let's welcome Prof. Stefan Haberth.
Dear colleagues, good afternoon. This is Stefan Haberth from Geneva, who will give you a talk about controversies in definition of ventilator-associated pneumonia. I would like to thank also my colleague, Dr. Vika from Madrid, Spain, who helped me to prepare this presentation. Unfortunately, I will not be able to participate in the discussion afterwards, since for family reasons, I will not be able to join live. This short talk will cover different issues surrounding VAP surveillance and the challenges related to definitions and diagnostic criteria. I will also talk about the new concept of VAE surveillance, its hypothetical advantages and flaws. Then I will briefly talk about the current differences and discrepancies in surveillance methods of VAP and VAE between Europe and the United States, and then I will briefly conclude. So let's first start with some conventional wisdom. The commonly accepted clinical definition of VAP includes the development of a pneumonia more than 48 hours after intubation. And historically, there was a distinction between early onset VAP, which occurs 2 to 4 days after admission and was most frequently caused by staph, strepto, Haemophilus, and the so-called late onset VAP, which occurs 5 or more days after intubation and is more frequently caused by either gram-negative bacteria or sometimes MRSA. Also, probably all of you know that most frequently the origin, the cause of VAP is of endogenous origin. It's commonly accepted that at least 3/4 of VAP episodes are linked to the endogenous gut flora of the patient, which then contaminates the oropharynx and due to microaspirations may cause pneumonia. There's a minority of episodes that are linked to exogenous sources. Here in that instance, for instance, it may be contaminated hands or ventilatory circuits. So what are the different definitions of VAP for surveillance purposes that are commonly used? The traditional surveillance definition for VAP includes as criteria a new or progressive infiltrate, worsening oxygenation, and a change in the quality or quantity of sputum. The definition that was used by the CDC until 2013 required at least 2 days of mechanical ventilation, radiographic change, new fever, alterations in white blood cell count, and at least 2 objective symptomatic changes, including, for instance, an increased purulent sputum or increased secretions. On the European side, the ECDC uses the following definition. VAP is a lung infection that develops in a patient who has been mechanically ventilated for more than 48 hours and is defined by clinical, radiographic, and microbiologic criteria. I won't go into all these details. But of course, as you all know, there are many concerns about the validity, the reproducibility, and interpretation of VAP rates, particularly in the context of large-scale national or international public reporting and benchmarking, because there are lots of caveats and difficulties when we talk about VAP diagnosis and definition. Because the most widely used VAP criteria and definitions are based on clinical signs or symptoms that are neither sensitive nor really specific. There is clearly ongoing difficulty with many commonly used VAP definitions that require radiographic findings of pneumonia, which of course do not accurately identify VAP, especially in critically ill patients. As you all know, for those who are in clinical care, most of those patients will need a true CT scan to really see what's going on, and a simple chest radiograph is by current standards not the standard of care anymore. So clearly there are challenges and difficulties related to the high levels of inter-observer variability when it comes to the diagnostic criteria for VAP, which makes it, as I mentioned before, quite difficult to use VAP rates to compare patient outcomes across health systems, meaning that in theory, it's just a poor quality indicator for monitoring of critical care related pneumonia episodes. And therefore, as I mentioned before, it's a real challenge to use and to implement national VAP surveillance because of the lack of objective, reliable definitions if we use the basic standard set of criteria that suggested, for instance, by the ECDC. But all this is not really new, because for decades, of course, there has been a very intensive discussion and debate, especially in the critical care community, about the best approach to diagnose VAP. There are the schools that defend invasive sampling. That means that using either rigid or flexible bronchoscopy with then bronchoalveolar lavage and quantitative cultures of the BAL fluid, or the other school that goes more for the clinical science, including the CPIS, which I will cover in a few slides, and semi-quantitative cultures of tracheal aspirates. But clearly, if you ask nowadays critical care physicians, they will say, oh, that's an old story. So just to show you, already 30 years ago, there has been this transatlantic debate between some gurus more on the United North American side that suggested that invasive sampling is not routinely needed to diagnose and manage suspected VAP, whereas the European school, mostly French and also Central European school, Germany, Switzerland, Northern Europe, they suggest that yes, invasive diagnostic testing should be routinely used to manage suspected VAP. So it's nothing new when we come from the clinical side, not necessarily from the epidemiologic side. But this has been now nicely confirmed by a very robust systematic review that was conducted by Mike Klompes and published in JAMA 15 years ago. He looked only at studies with a histology as gold standard to diagnose ventilator-associated pneumonia, included about 650 patients from 14 studies. And here you see the diagnostic performance of the different diagnostic approaches. So clearly, if you just use radiology with a new infiltrate or air bronchograms, it has pretty lousy positive and negative likelihood ratio, so not of much help. The only thing that you can observe here is that it has a very good negative likelihood ratio or negative predictive value. So if there is an absence of fever, radiologic infiltrate, purulent sputum, hypoxemia, then it's very unlikely that a patient has developed a VAP. In contrast, if you look at the more invasive or more advanced diagnostic tools, especially for lavage, you can see that it has excellent positive likelihood ratio. So again, very good positive, and also very good negative predictive values. So in the presence or absence of these kind of findings, you can be pretty confident that there is presence or absence of VAP. The same for the CPI score, which has also quite good diagnostic performance to rule in or to rule out VAP. So what's the CPIS score? It was developed by Jérôme Pugin here in Geneva more than 30 years ago. It includes mostly 6 variables like temperature, blood leukocytes, tracheal secretions, oxygenation, infiltrates, and semi-quantitative sampling of tracheal aspirates. It may vary between 0 to 12 points. And at that time, it was shown that CPIs correlates quite robustly with the results of BAL fluid results and bacterial culture. So here, this is a score that is still quite widely used around the world, both for clinical purposes, but also for epidemiologic purposes. And definitely that's a score, at least in Europe, that is widely used also for surveillance purposes to make the surveillance of VAP a more reproducible exercise, despite all the challenges that I mentioned before. So now, in the second part of my talk, I will now talk about the new concept of VAE and ask the question whether we are ready for a paradigm shift here. So what's VAE? It means Ventilator Associated Event. It was created about 10, 11 years ago at a meeting of a working group that was convened by CDC, where they came up with a new quality indicator for VAP surveillance, which was called VAE. And then 2013, the CDC replaced surveillance for VAP with a new VAE definition. The advantage, it's an objective, streamlined, and potentially even automatable process that can identify a broad range of conditions and complications, not only of infectious origin, of course, in mechanically ventilated adult patients. What are the implications of the shift from the VAP paradigm to the VAE definition? It broadened the focus of potential prevention to all major causes of respiratory deterioration in ventilated patients, so includes also pulmonary edema, ARDS, embolism, atelectasis, etc. It simplifies and even may allow automated surveillance, because here it's only focused mostly on objective markers of respiratory deterioration, and it doesn't focus anymore on pneumonia only. But it's even more complicated. So still, VAE, its overarching concept is that there is somewhat an increase in ventilator support after a period of stable or decreasing ventilator support. And patients must be ventilated for at least 4 calendar days. There are 3 definitions within this algorithm. There's VAC, the whole business of ventilator-associated condition. Then there is infection-related ventilator-associated complication. And you can see here on the right side, very crude diagnostic criteria, like just a fever, leukocytosis, and a new antibiotics. And then there is possible VAP. Since the initial introduction in January 2013, there have been several modifications to this concept. And very clearly, everybody, of course, says this is really not useful for clinical care or for any kind of clinical purposes. It's only for surveillance purposes. Here you see in this summary figure by Mike Klompes, the overlap between VAE and VAP. But you can see that there are lots of, as I mentioned before, lots of conditions that are of non-infectious origin. Then you have an overlap here, but then you may have quite a lot of clinically diagnosed VAP episodes that may not fulfill the full definition of a VAE. What's the epidemiology of VAEs? Just very quickly to give you a little bit of a feeling. VAE rates tend to be higher in trauma, surgery, neurosurgery units in larger hospitals. The risk for developing VAEs tend to be highest in the first 2 weeks of mechanical ventilation, but still remain present until extubation. Approximately 1/3 of VAE fulfill theoretically the IVAC criteria, but this varies by the type of ICU. And overall, the overall hospital mortality for VAEs is about 1/3, so it may be even slightly higher than the crude mortality rate for VAP. But there are flaws in this concept of VAE. First and most importantly, the IVAC surveillance paradigm fails to detect up to 95% of patients with VAP. This is a maximum number, but in most studies that compare these concepts, between 1/3 and 2/3 of VAP patients were not detected by the IVAC surveillance approach. Clearly, the IVAC is most often caused by non-infectious complications, like, for instance, heart failure, RDS, atelectasis, embolism, fluid overload, etc. Then there's also a low sensitivity of the IVAC surveillance paradigm, because it does not take into account any kind of radiographic findings. It excludes early onset VAP, and it also underestimates pneumonia in some of the most immunocompromised patients. So when we compare the VAP concept versus the VAE concept, 40% of clinically diagnosed VAPs most likely meet the VAE criteria. Definitely VAE misses many traditionally defined VAPs, which of course undermines preventive efforts. And then the utility as a QI tool has been really debated, especially in Europe over the last few years, because of this low positive predictive value for identifying pneumonias. And most importantly, concerns have been expressed that these events may not be easily preventable. So now I come to the last part of my talk, talking about the current differences between North America and Europe. And it's true that especially when it comes to VAE versus VAP surveillance, it's almost that we are living on two different planets, not only just an ocean between us. Indeed, the ECDC maintained the previous definition for pneumonia and VAP, as well as it was considered more relevant from both a clinical, epidemiologic, and preventive prevention perspective. This definition is still in line with most treatment and diagnostic guidelines from critical care societies, and also is aligned with many studies that demonstrate the effect of preventive interventions to control and prevent VAP. There's also been a meta-analysis recently that, as I mentioned before, that VAE surveillance does not detect reliably and accurately all cases of VAP. Also, the current CDC NHSN definition is really in great discordance with VAP surveillance. At least in another study, there was agreement in only 4 out of 61 cases of confirmed VAP. And therefore, at least the ECDC sticks to the old definition, because they also say it's a concept that is broadly applicable around the world, and it may also allow to compare international rates, as has been shown in the past for VAP studies when they compared the old CDC definition to the ECDC definition. So, of course, there are underlying explanations. So in the US, there has been a lot of outsourcing of lab capacities. Invasive sampling is much less frequently practiced in most smaller ICUs and mid-sized ICUs compared to Europe. Still, if you ask colleagues in the US, there is still a lack also of strong and evidence-based VAE prevention bundles. And also what you have to understand, of course, there has been very aggressive benchmarking practices of hospital-acquired infections, including VAP, with a lot of legal and financial implications in the US. So there has been an interesting article 10 years ago in the New England that showed that when CMS introduced a non-payment policy for preventable infections in US hospitals, there was really no impact on device-associated infections, also including VAP, as shown here. So VAP decreased already before the change in reimbursement policy. So it's a really debatable concept that hospitals should be punished if they have high VAP rates, but it may be an underlying rationale and excuse and reason why the US tried to somewhat leave the concept of VAP to a more broader concept, so that they may not be easily punishable by some agencies and payment organizations. In Europe, at the moment, there's still much less aggressive benchmarking, and insurance companies definitely don't punish hospitals if you have a high VAP rate. There is a culture of more invasive culturing, especially now that lots of ICU physicians learn to use mini lavage. There are still many more hospitals in Europe that have in-house microbiology lab capacities. And then last but not least, but of course very importantly, there are a lot of established and impactful VAP prevention bundles introduced in Europe, which is not the case for VAE prevention. And here, just an example, we published 3 years ago a VAP prevention bundle for our large adult ICU. And even now, there has been a sustained reduction effect over 7 years, despite the COVID-19 pandemic. So to conclude my talk, definitely on both sides, for VAP and VAE, those definitions should be used mostly only for epidemiologic surveillance and not for clinical care. There are still a lot of challenges and controversies related to accurate diagnosis and definition. Conventional VAP surveillance paradigm uses still non-specific markers and chest or radiographic findings. Therefore, invasive or sampling by mini lavage may be a helpful tool to increase precision. The CPIS score may still be a good compromise in settings without frequent invasive sampling. The VAE surveillance concept is definitely interesting, but it's still a theoretical concept. There are lots of barriers and doubts when it comes to real-life implementation. And most importantly, there is a paucity of rigorous prevention studies that have shown, if you target VAE in general, that you can decrease substantially also VAP and other conditions. Most importantly, I try to highlight that there is a gap in surveillance methods between the United States and Europe at the moment. And clearly, VAE surveillance is not widely implemented in most European countries and ICUs. If you ask critical care physicians in many settings, they don't even know about VAE. And most importantly, at the end, prevention remains the goal, evidence-based prevention. Here, definitely, we are still on the stronger side when it comes to VAP prevention compared to VAE prevention.
Okay, I would like to thank Dr. Hubbard. He's not here, but I think we'll thank him the same way for that excellent presentation that, compared and contrasted the VAE. So it gives me great pleasure to introduce our next speaker, Dr. Mo Lin. Is an infectious disease physician at the National University Hospital, Singapore. And she is the Deputy Director of the Advanced ID Network, which she'll be talking about and letting us know what it is. Her research interest is in antimicrobial resistance and emerging infectious diseases. She's the lead investigator for the REGARD VAP, which is Reducing Antibiotic Treatment Duration for Ventilator-Associated Pneumonia trial, and has conducted several multinational randomized trials. So Dr. Moin will be giving us a talk on treatment of VAP and AMR. Thank you.
Thank you for the introduction. A very good afternoon to everyone. I am Moin, an infectious disease physician from National University Hospital from Singapore. I also did a PhD with University of Oxford and remain a research fellow there. I think in the first two talks, there's been a lot of focus on data from America as well as Europe, as well as the guidelines and evidence from there. In my talk today, I'll be focusing on a clinical trial that we are concluding very soon with data from Asia, as well as some modeling results focusing on AMR and antibiotic treatment of VAP. So as we all know, no matter how much we try to prevent VAP, it remains the most common nosocomial infection in the ICU population, and it accounts for about half of all antibiotics used in the ICU setting. And estimates of all-cause mortality remains very, very high, about 20 to 50%, and in low to middle income countries, it can be as high as 90%. And VAP has been shown to prolong hospitalization by about 1 to 2 weeks, and also as well as mechanical ventilation by up to 2 weeks as well. So given its high prevalence and associated antibiotic usage, VAP is probably a very high driving factor behind AMR in the ICU setting. So I'm not sure if everyone is familiar with the series of EPIC studies. It is one of the largest observational studies in a global ICU network, and it's been performed 3 times in the past 3 decades. And surprisingly, little has changed in terms of prevalence of infection and associated mortalities. And these estimates are stable, if not rising, in low middle income countries. This is really fairly disappointing given that we've really focused on sepsis management in the recent years. And the high prevalence of multi-drug resistant gram-negatives likely reflect the overall microbiological environment or ecosystem in the ICUs. And this global trend is a major challenge with very limited treatment options available. So VAP is challenging to diagnose and manage, as Stefan has alluded to as well. So firstly, we continue to rely on conventional clinical, radiographic, and microbiological criteria to diagnose the condition since the 90s. And based on validation comparison with post-mortem biopsies, the sensitivity and specificity of our clinical criteria is only about 70 to 75%. And secondly, identification of specific causative pathogen is also difficult because our respiratory tracts are non-sterile. And concordance between tracheal non-quantitative cultures and cultures of lung biopsy is as low as 40%. And again, as Stefan has said, experts disagree on how to best sample the respiratory system in the diagnosis of VAPs. So the Europeans in 2017 published their guidelines jointly by the ICU Society, microbiologists, and infectious disease physicians. They would like invasive sampling with quantitative cultures. And this really reflects how conservative the Europeans would like with their antibiotics. However, in certain settings, especially in low middle income countries, that is quite limited. And other experts, especially from America, has recommended not to do invasive sampling and as well as semi-quantitative cultures. And that is mainly based on a very big Canadian study done in the ICU that's shown that invasive sampling does not improve mortality and does not reduce hospitalization duration. And all these factors result in overdiagnosis and overtreatment of VAP with empirical combinations of broad-spectrum antibiotics. I'm sure many of us in the room can relate to this problem. And lastly, which is what I'm hoping to focus on, is duration of antibiotics. Treatment for VAP remains in question. So I'm sure everyone is aware of the two notable French studies published more than a decade ago now that says short duration antibiotics, 8 days versus 15 days, they are comparable. However, also in these studies, it's been found that gram-negative non-fermenters, such as Acinetobacter and Pseudomonas, they may have increase in recurrence if we give short duration of antibiotics. And there are also important biases in these studies. For example, long-duration therapy is favored because the time to follow up until the end point of the study is shorter, and therefore in short-duration patients, the chance of detecting a recurrence is higher. And secondly, persistent colonization may be erroneously identified as a recurrent pneumonia episode instead of a recurrence episode. And of course, there's a potential of subgroup over-analysis. And so putting these together, these trials really limit our applicability of these trials in our Asian setting because most of our VAPs are caused by Acinetobacter and Pseudomonas. And currently, the available studies also suffer from lack of evidence on culture-negative episodes or episodes with unknown organisms. So overall, there is a crucial need to better define duration of treatment. And as you can see here, this is really the last step of management for VAPs. So this leads on to our REGARD VAP trial, and that stands for Reducing Antibiotic Treatment Duration for Ventilator-Associated Pneumonia. The data I'm showing is first time in seeing daylight. It is a hierarchical non-inferiority superiority study which compares short versus long course of antibiotic treatment. The unique point about this study is that it allows for individualization of duration. So as the patient responds to antibiotics, we will randomize the patient to stopping antibiotics immediately or prolonging antibiotics as physician preference. And what we are looking for is 48 hours of afebrile, of fever subsiding, as well as stable blood pressures. And the primary outcome is a combined one, is a 60-day mortality as well as pneumonia recurrence. And the trial sample size was calculated with a sequential group design with 4 interim analyses. So the trial is being conducted in over 40 ICUs in 7 hospitals in Asia. They are in Nepal, Thailand, and Singapore, and this consists of hospitals of really wide-ranging resource and clinical settings. We started enrollment since 2018 and have achieved over 90% enrollment since then. As of today, we have about 433 patients. It's been really hard over COVID, but I'm hopeful that the trial will end by the end of this year. So here I share the patient and microbiological characteristics from the first 345 patients, which informed our third interim analysis. As you can see here, the average age is about 62 years old, mainly males. And the comorbidities mainly we see are diabetic patients, 23%, chronic kidney disease patients, 15%, cardiac failure patients, 10%, and chronic obstructive pulmonary disease, 9%. The mean SOFA score in these patients is about 6 to 7, which translates to about 20% mortality. So I do believe this is the typical kind of patients that we see in our ICU setting as well. So in terms of microbiology, I hope the font is not too small. The vast majority, of course, is caused by gram-negative organisms, 95% of these episodes. And the commonest gram-negatives that we see are carbapenem-resistant Acinetobacter, as well as Pseudomonas group. And interestingly, we did not pick up many ESBL producing or third generation cephalosporin-resistant Enterobacteriales. So, of course, the focus is on carbapenem-resistant gram-negative bacilli because the evidence behind treating these organisms are really non-existent. So 70% of our patients enrolled into the trial had combination antibiotics, and for the 101 episodes of carbapenem-resistant gram-negative ventilator-associated pneumonia, we saw 43 different combinations of antibiotics. And breakdown of these antibiotic combinations are seen in this table here. We can see for carbapenem-resistant Acinetobacter, cephalosporin and sulbactam, colistin, tigecycline are the commonest antibiotics used. For Enterobacteriales and Pseudomonas, the commonest antibiotics are colistin, polymyxin, and high-dose carbapenems. So we randomized our patients to short arm and long arm. Although I cannot show you the results of mortality and pneumonia recurrence before these two arms, here we can see the efficacy of our randomization. So the blue line represents the patients in the short arm, and the yellow line represents the patients in the long arm. So in the long arm, physicians are free to give antibiotics for as long as they like. As we can see here, the median duration is shown by the dotted line here, and that's about 2 weeks. And 25% of the patients receive about 3 weeks of antibiotics. And this is in stark contrast to the French studies and European and US guidelines. And for our patients that's randomized to the short arm, we managed to reduce the duration to about 6 days median duration. So I can share with you the overall intention to treat population outcomes. The mortality is about 37%, so that is higher than the expected 20% from the SOFA score alone. And the recurrences determined by 2 independent assessors is about 13%, which is a lot lower than what's been reported before in the French studies, which is about 40%. Hopefully that means that we are more discerning. And if we look at both outcomes, mortality or recurrences or both, the primary outcome is about 42%. And we all can look forward to the final publications expected in the middle of next year, hopefully. So of course, the question is, does shortening duration necessarily reduce AMR carriage? However, this remains a hypothesis, even though all our antibiotic stewardship programs that I'm aware of attempt to stop antibiotics early. But this question has never been looked at in terms of trials and very, very limited observational study as well. So to elucidate this problem, we performed mathematical modeling and a systematic review to look at both individual and population level impacts of reducing duration on AMR carriage. So over at this graph here, the left-sided panels I'm sorry you can't see my mouse, but the left panels refer to the duration of antibiotics effect on individual patients. And over on the right side, it refers to the duration of antibiotic effect on the population in the hospital ward. So on the left upper corner, you can see that when we give an effective antibiotic, for example, a carbapenem on an ESBL-producing bacteria, we expect all the bacteria that's carried by an individual to decrease because antibiotics can effectively kill these bacteria. However, when we give, say, a carbapenem to a patient carrying carbapenem-resistant bacteria, we would expect the resistance to be selected and increase within treated hosts, while the susceptible ones, perhaps ESBL-producing bacteria, to be reduced. So when we look at the population level as well, if we were to give a very broad spectrum coverage for all the patients in the ward, we will expect the carriers to decrease within the ward. And the effect of that for between-host transmissions will decrease as well because the overall number of patients carrying resistance have decreased over time. However, if we were to give, say, a carbapenem to a ward full of carbapenem-resistant carriers, we will expect the number of carriers to increase over time and also facilitating transmission events to increase over time as well. So to validate our hypothesis and what I've shared with you earlier, we built three models, agent-based models, represented by these three colors over here, and looked at three types of outcomes. We looked at outcomes in treated individuals, the first horizontal two graphs here. The second population we looked at was the overall ward population, and the last outcome we look at are the patients who who are non-carriers but discharged as carriers. So as you can see here, all three models give similar outcomes. What are the outcomes then? So again, when antibiotics prescribed are very, very broad spectrum, reducing duration does not necessarily lead to less carriers. That's counterintuitive. That is because previously, in the previous slide that I've shared with you, reducing duration on very broad spectrum antibiotics may actually increase carriers due to ineffective killing of resistant bacteria. And in the other case, when the antibiotics given are not very broad spectrum, say ceftriaxone for ESBLs, we do expect in all three populations that prolonged duration will lead to more carriers. So again, to validate our model findings, we went through over 2,000 papers and found 187 antibiotic duration randomized controlled trials. And maybe unsurprisingly, we've only found 8 studies that collected colonization cultures. And only 5 out of these 8 collected gram-negative bacilli carriage data after the antibiotic has been stopped. And I put all these data into a meta-analysis, and the key finding is that there is indeed a 7% increase in daily probability of acquiring resistance carriage, given a baseline carriage of 10%. So what this means is that, well, I personally think that this is fairly useful for clinicians when we try to stop antibiotics during our stewardship rounds, is that prolonged duration, one additional day of antibiotics may be associated with up to 7% increase in carriage. So to continue investigating on how to best manage, prevent, and diagnose resistant infections, together with Professor David Patterson, who happen to be in other symposium right now, we are establishing a new large collaborative trial network focusing on antimicrobial resistance called the Advanced ID Network. I'm sure in this room we have approached many of you as well. The main goal of the network is to embed best research practices in AMR hotspot areas to conduct effective and efficient interventional trials through training and providing equipment and education as well. Also, we would like to streamline regulatory approaches, including ethics approvals, data management, transfer, and sharing. And with the strength in numbers we have here in Asia, we are keen to develop innovative trial methods and designs and focus on pragmatic and clinically relevant trials to directly impact clinical decisions. A little bit on our first study. We are embarking on a ACON-HI study, which is a prospective observational surveillance study that collects 4 types of data: clinical data, microbiology data, genomic, as well as health economic data. So the goal is to mainly estimate AMR disease burden and assess current treatment practices. And currently, we've engaged over 30 hospitals across Asia. And this is an excellent foundation for further collaborative treatment and diagnostics randomized trials. So that is my last slide, and I thank you very much for your attention, and I look forward to working with all of you.
Thank you, Moin, for that very interesting talk. And also, I think it's very timely that we have something like this in Asia. It's always been in Europe and US, and I think we really need a network like this. So whoever is who wants to network and get their hospital involved, I'm sure you can meet Moin after this, I'm sure. All right. We've got, is there any questions? We open to the floor. Do you have? If there isn't, there are some questions here. It's for Professor Stefan Hubbard, but he's not around today. There are 2 questions here. I can try to. So the first question is, critical care units tend to use VAE as official definition, and thus does miss quite a bit of true infection VAP. And often it's not open to proactive intervention. Their reaction is more reactive. Can you share your experience? So maybe I could just say, so in Malaysia, I think the critical care units, anyway, based on my experience, I think it's not very standardized. Some ICUs use VAE, some use VAP, and but I think most of them still use the CDC's VAP rather than VAE. And even if they use either one of it, it's not very standardized. And I get your thing that they tend to be reactive rather than putting in interventions. But either whether it's VAE or VAP, I think the interventions that you put in should be able to reduce either one. So you should be able to see a reduction in the trend, as I showed in the earlier meta-analysis and studies. A lot of them the IDSA picked up studies that looked at outcomes, VAE sort of outcomes more than just VAP, but a lot of them actually had VAP in there, and those interventions should bring it down. So I think for now, either whether they look at VAE or VAP, if you will stick to something and at least you have a data to look at the trends, and then you put in your intervention and you can decide. What's your input on this?
Thank you. I think maybe Catherine has more perspective than me because you're actively doing surveillance. So I would just like to stress that I agree that the definitions of VAP and VAE are mainly for surveillance purposes. As long as we stick to one and look at the trend, that is for our population level assessment of our interventions and policies. I understand that in the day-to-day, how we decide treating the patients is, like I shared in a flow chart earlier, is very, very different. Yeah.
And from our perspective in Singapore, we are actually doing VAE surveillance. And as what Dr. Prof. Stefan Hubbard shared, that there are a few components of VAE, so which is the VAC, the IVAC, the PVAP, and finally VAP. So VAP is also covered, but as a subset of VAE. And we actually base it because of the MOH guideline that came out a few years back, and which is actually adapted from NHSN.
There's another question for Prof. Hubbard, and I would like to know about CPIS. Since it was released in 1991, I read in a systematic review and meta-analysis that the accuracy and performance in diagnostic VAP is not accurate. Would you please share your experience? Thank you. So I think Moin will go for this.
Perhaps I can share my perspective. So CPIS has been validated against biopsies, as Stefan has shared. However, it is also been criticized to be non-specific, and some of the criteria can be fairly subjective. So it is a problem, especially when including such an outcome in clinical trials. And also, if you were to read the guidelines from IDSA, from the American side of things, they do not recommend using CPIS to diagnose VAP. Yeah, so I would agree with that meta-analysis. Yeah.
Any other questions from the floor?
You may proceed to the microphone here to ask your questions. Perhaps I can ask Dr. Susila. You mentioned quite a number of strategies. I would like to know what are the strategies that you implemented in your medical center, and did it help your VAP rates?
Yeah, so I must say that if you're talking about my hospital itself, I always found VAP the most difficult HAI to prevent. So when I went in, I started my position, I went for CLEP-C first because I felt it had a higher mortality. It was more objective in your surveillance definition. VAP, the surveillance definition was all over the place. The ventilator bundle, if you look at the data, the crude mortality is about 18%, but the attributable mortality to VAP actually may be much lower. And most of it was shown to be due to the underlying disease itself rather than VAP. So I always thought, I was always too scared to go into it and look into it. So in our hospital, we still use the 5 things, which is raising the head, try not to intubate, to get patients out of sedation as quickly as possible. Oral care, but we still use chlorhexidine, and since this guideline came out, we are re-looking at our own data to see how things are going. I must say our rates of VAP, our national KPI for VAP is to have less than 10 per 1,000 ventilator days of VAP. Our rates can fluctuate anything between 8 and 20, depending on the month. And with COVID, of course, it went up. And I think I see it coming down when our nurses or healthcare, even doctors, how they handle the tube actually. So, whether you change your gloves before you touch the different parts of the body, from clean to dirty and things like that. So I think it all boils down. I mean, the bundle should be there. I think you can choose about 5 or 6 bundles that you want to put in. But I think hand hygiene, gloving, and doing a hand hygiene before gloving and after gloving is a very important component. If not, why would you see things like enterococcus or a gut organism in your ventilator-associated pneumonia? I mean, translocation happens, but most of the time, it's through contamination. So I think that's my experience.
Thank you, Dr. Sheila. Any more questions from the floor?
Maybe I can take the opportunity to do a little poll. I understand there are representatives from almost every country around Singapore. So I'm wondering if there's any national surveillance programs for VAP. I understand that Malaysia has one and Singapore has one as well. So just a show of hands, what about Thailand? Is there a national surveillance? Anyone from Thailand here? Yes, I heard Thai just now. There is a national surveillance? Yes, okay. Okay, what about Vietnam? No one from Vietnam. Okay, any other countries that's doing? No. Okay, not in Vietnam. Okay. Any other countries that I have not asked? And you have a national surveillance program or? Okay. All right,
I want to ask you a question about your study, and I found that really interesting. I might have missed it, but I was wondering, when you had your 2 arms of long duration and short duration, the did you take into consideration the organism, and what about the antibiotic? Was it up to the clinician to decide what they were giving?
Yes. So the antibiotic choice, we just went with the cultures. So as long as the culture has showed that certain antibiotic is acceptable, then we allow the physician's free will to choose. In terms of the organism-wise, we don't have a specific duration for each organism. We wanted to disprove, we are hoping to disprove that gram-negative non-fermenters needed longer duration, which is really the driver why we are still treating VAPs in this region for so long. And actually, there is another French study that is either publishing soon, or I understand it's already been accepted, that specifically looked at Pseudomonas VAP and duration of treatment as well. Unfortunately, it's another arbitrary 7 days versus 14 days. And in our trial, it's mostly Acinetobacter and Pseudomonas. Hopefully, we will see similar results as the other trial. Yeah.
Thank you. You have left us with a cliffhanger.
That's the point of my talk.
Any questions? Well, if there's no questions, I think you can go out and enjoy the posters and get a drink before the next session. Thank you, everyone. And thank you, Moin.
So I'd just like to remind everyone that you need to complete 3 forms for 3 days in order to receive your certificate of attendance. So please scan the QR code and do the survey.